Welcome to NephroTube Nephrology Online Lectures. In our lectures, we discuss mainly Oxford Handbook of Nephrology and Hypertension, and we also discuss the new updates in nephrology. In this lecture, we will talk about an important practical topic, renal replacement therapy in acute kidney injury. As we always mention, that the PowerPoint of all our lectures available at nephrotube.com. Videos in both Arabic and English languages are available at our YouTube channel NephroTube, and also you can join our Facebook group. We are now more than 11,000 members. We post daily MCQs and cases, and you can also follow us on Twitter and our Facebook page. Regarding the dialytic management of acute kidney injury and dialysis in acute kidney injury and septic patients and the critically ill patients, 4 important questions to answer: when to initiate dialysis in these category of patients, when to stop dialysis, what is the best modality, and what is the dose. In each part of these 4 parts, we will try to discuss the available evidence to support our data. Let's start when to initiate. We always have a problem regarding dialysis initiation in acute kidney injury, whether to start or to initiate dialysis early or late. But the question is, what is meant by early dialysis and what is meant by late dialysis? Different studies compared the initiation of dialysis in acute kidney injury early versus late, but different definitions of early and late initiations are used. Some studies define early or late according to serum creatinine, some define early versus late according to the level of serum urea, some according to urine output, and some according to time from ICU admission or duration of acute kidney injury. And even those who used serum creatinine to define early versus late used different levels of serum creatinine, and the same for urea and the same for urine output. So we don't have clear definition for acute don't have clear definition for early versus late. So when to dialyze? This is a debate and the problem. As was mentioned in Oxford Handbook and KDIGO guidelines 2012, that it's better to take the decision for dialysis according an important point, which is to use a pragmatic approach and to consider the broader clinical context, the presence of conditions that can be modified with renal replacement therapy, and the trends of laboratory tests. So you have to take the patient as a package, broader clinical context. Will the patient will get a benefit from the dialysis or not? Will the dialysis increase the patient mortality and morbidity or not? Yes, it is a vague concept. It is not clear, no sharp line defining when to start dialysis, but that was recommended or suggested by KDIGO. And KDIGO mentioned in their rationale that you may consider renal replacement therapy starting from AKI stage 2, which is defined by rising serum creatinine 2 to 3 times, nearly 3 times baseline, or decrease in urine output less than 0.5 ml per kilogram per hour for more than 12 hours. Okay, let's see what is the new available evidence regarding when to initiate hemodialysis or dialysis in patients with acute kidney injury and critically ill patients. I will mention the most recent 2 systematic review and meta-analysis. This one, published this year early in 2020, a systematic review and meta-analysis testing the timing of renal replacement therapy for patients with acute kidney injury, whether it is early or late, whatever the definition of the studies in the meta-analysis. What is meant by early or late? They compared all the studies that tested early versus late initiation of dialysis in acute kidney injury. The end result that they found and concluded that no significant difference between groups were evident, early versus late, were evident for period-wise mortality, dialysis dependence, recovery of renal function, length of intensive care unit or hospital stay, number of renal replacement therapies, mechanical ventilation or vasopressor therapy. No significant difference between what is called early and what is called late renal replacement therapy, whatever the definition the different studies used. So it's logic to start late as possible. So the current evidence in this study doesn't support, in this meta-analysis, doesn't support the use of early renal replacement therapy for patients with acute kidney injury. More recent, a published trial in May 2020, a systematic review and meta-analysis also, comparing delayed versus early initiation of renal replacement therapy for severe acute kidney injury. There was no difference between early and delayed renal replacement therapy, whatever the definition of early and delayed renal replacement therapy used in different studies. There is no difference regarding survival probability. So the final conclusion that timing of renal replacement therapy initiation doesn't affect survival in critical patients with severe acute kidney injury, but there are some important points to consider. Timing doesn't affect survival in AKI in absence of urgent indication of renal replacement therapy, because if there is an urgent indication for renal replacement therapy, we have to start dialysis immediately, as we mentioned. So delaying renal replacement therapy initiation with close patient monitoring may lead to reduced use of renal replacement therapy, and also it may save health resources. So the recent evidence goes with delaying the initiation of renal replacement therapy in acute kidney injury as possible, except if there is absolute or relative indications for dialysis. You may start dialysis immediately and don't wait. Let's summarize these important indications. As it was mentioned in KDIGO, if there is life-threatening indications, you have to start dialysis immediately. What are these indications? Fluid overload refractory to medical measures, hyperkalemia refractory to medical measures, severe metabolic acidosis also refractory to medical measures, and signs of uremia, especially pericarditis, neuropathy, or unexplained decline in mental status, and finally certain alcohols and drugs. In the absence of these factors, these life-threatening indications, there is a general tendency to avoid dialysis as long as possible. Also, as it was mentioned in Oxford, hyperthermia may be an indication. As we said, poison or toxin removal, like lithium, ethylene glycol, and as we said, diuretic-resistant cardiac failure, it is considered as refractory volume overload. So, it is apparent that what may be early for one patient could be late for another. And I like to summarize all what I mentioned and I said till now regarding dialysis initiation in AKI in one word. Always dialyze once indicated. Always dialyze once indicated. In the presence of urgent indication for dialysis, or late if possible in absence of these indications. Why are we trying to delay renal replacement therapy? Because renal replacement therapy itself has potential complications regarding the dialysis access insertion, hemodynamic strain on the patient, electrolyte imbalance may occur, complications with anticoagulant, and dialysis disequilibrium that we will mention later. So in absence of urgent indication, it's better to start dialysis late, and it may be preferable to delay dialysis and perform it as a planned daytime procedure under adequate supervision and in the presence of all your team. Don't dialyze the patient at night in absence of full support of your unit. except if it is an urgent dialysis. Let's take a case discussion to get the message of what we said. This is a 67-year-old woman with history of diabetes and CKD. Her baseline creatinine was 1.2, is admitted to the hospital for urosepsis. The patient treated with antibiotics, resuscitation with ringer lactate solution, and vasopressors. On day 3, hospital day 3, the urine decreased and doesn't improve after treatment with furosemide 1 mg per kilogram intravenously. So she is diuretic resistant. The patient's hospital course is summarized in table 1. I will show you now table 1. We have to decide now which one of the following is the most appropriate time for initiation of renal replacement therapy in this patient. Day 1, day 2, 3, 4, or 5. I will show you now the data. So this is a patient with urosepsis under antibiotic coverage, resuscitation with fluids and vasopressors, and she is diuretic resistant. Those are the lab investigations, clinical data of the patient. Let's check it. Regarding oxygen supplementation is increased from day 1 to day 5. The highest was in day 5. Regarding physical examination, her blood pressure was maintained 90/50. No evidence of volume overload. Second day, blood pressure raised. No evidence of fluid overload. Third day, blood pressure raised more. No evidence of severe volume overload, just trace leg edema. Day 4, blood pressure is good, but there is decreased breath sounds at lung bases, trace leg edema, and in day 5, crackles started to appear, indicating pulmonary edema, and there is 1 plus leg edema. So volume overload started to appear significantly in day 5, slightly increased in day 4. Regarding urine output, it was good in day 1, day 2, day 3, started to decrease in day 4, and severely decreased in day 5. Regarding her potassium, it was 3.7, 4.1, 4.8, 5.2, 6.2. Regarding her acidosis, total CO2 was 18, total CO2 indicating the level of serum bicarbonate, 19, 18, 20, and finally 15. So, and the creatinine is doubling. It was 2, 2.9, 3.8, started doubling since day 2 or day 3, 4.9 and 6.2. Through the evidence that we mentioned, which day you will start dialysis in this patient? I will give you 15 seconds to answer. Yes, it is day 5. In practice, some physicians may start in day 4. Okay, it may be possible to start in day 4, but according to available evidence, the most accurate answer may be day 5, as in day 5, this patient now has metabolic volume laboratory indication for initiation of renal replacement therapy. Let's take another case. A 70-year-old woman is evaluated for acute kidney injury after 4 days after coronary artery bypass. Serum creatinine raised to 3 from 1.2. Potassium is stable. Acid-base status is within acceptable limits. So she is at the level of laboratory results. She is good, except for rising of creatinine. Urine output is good, about 2 liters per day with diuretic therapy. She continues to require oxygen supplementation. She hasn't required vasopressors. She is not on vasopressors. On physical examination, she is intubated and sedated. Good oxygen saturation. Blood pressure is good. Pulse is good. The median sternotomy site shows no erythema, no infection at the scar of the operation. There is trace ankle edema. Examination is unremarkable. Sodium is good, potassium is good, total CO2 is 20, creatinine is 3, pH is 7.37, PCO2 is 36 millimeter mercury, PO2 is 88 millimeter mercury. Urine shows muddy brown cast, shows the case is diagnosed as ATM. Which one of the following is the most appropriate management? You will start renal replacement therapy, whatever its type, continuous renal replacement therapy. You will start intermittent hemodialysis. No additional management. Begin phenol-dopam. I will give you 15 seconds. This is a case with stable lab and clinical situation with only rising serum creatinine, and she has good urine output. So the answer is no additional management is needed, and delay renal replacement therapy as possible in the absence of urgent indication of dialysis. So now we answer the first question, which is when to initiate. Let's start when to stop. Another debate. I started hemodialysis for the patient, but I don't know when to stop hemodialysis. As was mentioned in Oxford Handbook of Nephrology and Hypertension, that assessment of renal function during renal replacement therapy is difficult. I can't assess renal function in an accurate method, and this may affect my decision. So you have to depend on trends, not a single number of serum, urea, electrolytes, and creatinine. Can I measure urinary creatinine excretion to detect the creatinine clearance in this patient if he has urine output? Yes, but again, it is not accurate and very rarely undertaken in practice, although some studies mention it. Let's take a general concept when to stop. As it was mentioned by Kirill, a general concept to stop when the intrinsic kidney function has recovered to a point that it is adequate to meet patient need. But again, this is a vague situation, a vague concept. I need to have a more accurate, clear data to know when to stop hemodialysis in these patients. We have to know also another important points that in intermittent hemodialysis, if you dialyze your patient 3 to 4 hours per day, 3 to 5 days per week, so there will be fluctuations of solid levels, and this prevents achieving a steady state, which will not help you to accurately test the renal function. And also in patients with acute kidney injury, especially if they have high metabolic rate as in septic patients, changes in blood urea, nitrogen, and creatinine may be modified by non-renal factors. But in CRRT, continuous renal replacement therapy, with a stable solid clearance for 48 hours, may allow more reliable management of creatinine clearance by native kidney, because after 48 hours of CRRT, the patient may reach a steady state, provided that his medical condition is not deteriorated. So those were general concepts. Let's talk about some evidence, available evidence. This one study used creatinine clearance to detect or to decide when to stop renal replacement therapy. They used creatinine clearance more than 15 ml per minute as a target to terminate therapy. Patients with creatinine clearance more than 15 ml per minute, they decided to stop. Again, one of the most important trials in the assessment of kidney function and test and the test of the renal replacement therapy in critical care patients, the ATN trial, they used this creatinine clearance parameters for the decision of continuation or stoppage of hemodialysis in critical care patients. The creatinine clearance more than 20, they discontinued renal replacement therapy. Below than 12, they continued renal replacement therapy. Between 12 and 20, decision was left to the physician and the providers. Okay, but how they measure the creatinine clearance in acute kidney injury? First of all, it is mandatory that to depend on creatinine clearance assessment in critically ill patients that the patient urine output is more than 30 ml per hour. How to measure creatinine clearance in these patients? They collected urine in this study at 6 hours, and they took midpoint serum creatinine, and they estimated the creatinine clearance. Another way, they collected the urine at 6 hours, then they measured same creatinine at first and the 6th hour, and they take average serum creatinine. But as it was mentioned in Oxford, the measurement of creatinine clearance is not practical and is not used. Another important parameter to decide when to discontinue renal replacement therapy is the use of the clinical parameters of the patient. This study tested different clinical parameters to depend on it to decide when to stop hemodialysis. They found that urine output at the time of initial cessation of continuous renal replacement therapy was the most important predictor for successful discontinuation, and it was followed by the improvement of arterial blood pressure. They found that the discontinuation of renal replacement therapy, depending on the volume of urine output, is the best indicator for the better performance of the patient who is critically ill. Patients with urine output of average 1.5 liters compared with other or less volume of urine output when the renal replacement therapy was discontinued had the better outcome regarding the increase in urine output later, the metabolic state, the fluid overload improvement, urea creatinine level, and hemodynamic stability. So when you discontinue renal replacement therapy in patients with good urine output, you will have better outcome later regarding these parameters. Patients with an average urine output 1.5 liters ranging from 600 to 2050 milli of urine output had better outcome than less urine output. Okay. And that was mentioned in Oxford, that increasing urine output is particularly helpful, although the use of diuretics will need to be factored in. And I have to mention here that it is important to know that KDIGO didn't suggest using diuretics to enhance kidney function recovery or to reduce the duration of frequency of renal replacement therapy. The only indication of diuretics in acute kidney injury is when the patient is volume overloaded. The only indication is the patient volume overloaded. If the patient is volume overloaded, you have to give a trial of diuretics. If no response, you will go to hemodialysis without diuretics. If you went to hemodialysis and the patient recovered, but later on the patient had oliguria again and start to be volume overloaded, you have to retry diuretics, and if no response, you have to start renal replacement therapy again. So we have an indication, or we have some parameters that we will depend on to discontinue renal replacement therapy, which is mainly the clinical situation of the patient, and the most important is the urine output. Another indication to stop renal replacement therapy when renal replacement therapy is no longer consistent with the goals of care, and the patient prognosis is very bad, and you may have to go through good end of life care as a palliative measure for the patient. Okay, now we discussed when to stop, but the question now, how to stop? The process of stopping renal replacement therapy may be consists of simply discontinue the method of renal replacement therapy you are using, or you may change the modality. If you are using CRRT, you may use intermittent hemodialysis or whatever. You may change the frequency or duration, and you can gradually discontinue renal replacement therapy. No consensus or studies available to show the best evidence of how to stop, but you may use one of these methods. Okay, now we discussed when to initiate and when to stop. Let's see what is the best modality. The ideal modality of renal replacement therapy of AKI is unknown, and the modality or the choice of modality depends on many factors, mainly the availability of the modality and the hemodynamic status of the patient, as I will say now. Regarding peritoneal dialysis, usually its use is not frequent in AKI, except maybe in some pediatric practices. Different modalities of hemodialysis can be used. They mainly classified into intermittent hemodialysis, whatever it is, hemofiltration, hemodialysis, or hemodifiltration, prolonged intermittent renal replacement therapy, the same filtration, dialysis, difiltration, but for a longer period or duration, or if I used it for a more or for a longer duration, it will be converted into CRRT. There is a PowerPoint presentation on nephrotube.com discussing the physiological principles of these different hemodialysis techniques, CRRT, intermittent hemodialysis, and prolonged intermittent renal replacement therapy. And we'll discuss it later in the chapter of dialysis in Oxford Handbook of Nephrology and Hypertension. But I will summarize the main concepts of the different techniques of dialysis. In hemodialysis, the blood is moved from the patient through the artery and returned back through the venous, passing through the dialyzer. In the opposite direction of the blood, there is a dialysis solution, so the blood is moving in this direction, and the dialysis or the dialysate is moving in the filter in the opposite direction, and there is exchange between the blood and the dialysate. The forces used to exchange between the blood and the dialysate, diffusion is the main force, and some convection to ultrafiltrate the fluid, extra fluid, or the fluid overload from the patient to the dialysate and drained away. If we use this technique for a longer period, it will be called CRRT, continuous veno-venous hemodialysis. If we use it for a short period, it is called hemodialysis, and if it is used to intermittent period, it will be called prolonged intermittent renal replacement therapy. There is another way or modification from the hemodialysis, which is a prolonged intermittent way called SLIT, sustained low efficiency dialysis. It uses the same technique of hemodialysis, but for a longer period, 6 to 12 hours. This is the prolonged intermittent method for a longer duration and with a low dialysate and the blood flow between 100 and 300 milli blood and dialysate flows. We'll discuss now when to use different methods of renal replacement therapy. The second technique is hemofiltration. In hemofiltration, there is no dialysate, so there is no diffusion in this method. It mainly depends only on convection and ultrafiltration. And if we use it, we have to replace the patient with fluid, because convection and ultrafiltration will make the patient lose a large volume of fluid and electrolytes. So we have to replace some of what the patient lost. May we replace it pre-dilution before the filter or post-dilution, and we will discuss these details later in the hemodialysis chapter in Oxford Handbook. If we use this method for a long time, it will be called CRRT, continuous veno-venous hemofiltration. So hemodialysis depends mainly on diffusion and to a lesser extent or less extent on convection. Hemofiltration depends mainly on convection with a replacement fluid. If we combine both of those, we will get hemodifiltration. Hemodifiltration is a mix between hemodialysis and hemofiltration. There is a dialysis with convection and diffusion, and there is a high convection with renal replacement therapy with a renal replacement fluid as in hemofiltration. So there is a high diffusion and high convection ultrafiltration in this method. If we use it for a long period, it will call be CVV-HDF, continuous veno-venous hemodifiltration. This is what is called online HDF. Online HDF, that the replacement fluid will be formed or produced by the dialysis machine itself. The replacement fluid in general, we can get it by two ways. The first way, we can buy it from a company, a ready replacement fluid in a bags, and we attach it to the machine. Or the second method, by making online hemodiafiltration. The machine itself produce the replacement fluid from the water treatment unit and the dialysate, mix them and make the replacement fluid and supply the patient with it. Finally, and the last method, we have what is called SCUF, slow continuous ultrafiltration. It is the same as hemofiltration, but without replacement fluid, but the convection and ultrafiltration is less in this case. So this was a summary of a large lecture that we will discuss later. Okay, which modality we will use in this patient? We discussed two major concepts of modality, the intermittent dialysis and the prolonged dialysis. Which modality is better? Let's talk about hemodynamically stable patients. If the patient is hemodynamically stable, the evidence available compared the intermittent therapies, renal replacement therapy, versus continuous renal replacement therapies. The end result in the evidence showed that there was no difference, that there was no statistically significant difference between intermittent and continuous renal replacement therapy regarding in-hospital mortality, ICU mortality, and recovery of renal function. So in hemodynamically stable patient, you can use continuous or intermittent therapy. So it is logical to use intermittent therapy, as it is most popular and available in all hemodialysis units. Yes, you may use intermittent hemodialysis therapy in a different duration. The classic use of intermittent hemodialysis therapy is 4 hours, 3 times per week, but in acute kidney injury patients, you may use it for a longer, or the frequency may be more, as I will mention later. But we have to conclude now that there is no difference between continuous and intermittent renal replacement therapy in patients with AKI and who are hemodynamically stable. But what about hemodynamically unstable patients or patients with increased intracranial pressure? Key guidelines and Oxford and the available evidence mentioned that and suggested that we have to use continuous renal replacement therapy rather than intermittent renal replacement therapy in these patients. Why? The available evidence showed that CRRT improved the patient's mean arterial blood pressure, and there was a difference regarding escalation of the pressor therapy, and it was better in patients with CRRT. So though there is a controversy regarding the optimal modality of renal replacement therapy, in clinical practice, the choice of which modality we will use depends on the patient hemodynamic status. As we said, if he is hemodynamically stable, you can use intermittent therapy or continuous, and we will prefer intermittent as it is more available. If the patient is hemodynamically unstable, so you have to use CRRT. But there are two important points regarding the choice of modality, which are the availability and experience. The patient is hemodynamically unstable and it is indicated to use CRRT, but what if your center is not doing CRRT good? Or what if the CRRT is not available? Or what if the staff present in the unit have no good experience how to use CRRT? So if I use the CRRT in this situation, the patient condition may be deteriorated more. So the availability and experience are important beside the patient hemodynamic status. Okay. Let's summarize again. In the presence of hemodynamic instability, it's better to use CRRT. Okay. But what if CRRT is not available? You may use one of the prolonged intermittent renal replacement therapy, which is SLED. The SLED technique can be done on the traditional hemodialysis machine, but with a less or a lower dialysis parameters. You will decrease the dialysate to 100 to 300, you will the dialysate flow, you will decrease the blood pump to 100 to 300 ml. You can use low flux dialyzer, and you dialyze the patient 6 to 12 hours. So the use of this technique will make the dialysis session quality is low, and it will not cause a hemodynamic stress on patient. And once hemodynamic stability is achieved, you can switch it again to standard hemodialysis. So to finalize this point, if the patient is hemodynamically stable, you can use intermittent renal replacement therapy or CRRT. If the patient is hemodynamically unstable, you have to use CRRT. If CRRT is not available, you can use SLED. Okay, last question. If I will use CRRT, which method is the better? We mentioned that CRRT we have continuous CVVHD, CRRT in the form of hemodialysis, in the form of hemofiltration, and in the form of hemodiafiltration. We have three methods of CRRT. Which one is better to use? Again, there is no evidence that one method is better than the other. Use whatever the method you will use according to the availability or experience. So there is no evidence that one method of CRRT is better than the other. Here are the different modalities with different advantages and disadvantages, as was mentioned in KDU and Oxford. The main idea of CRRT than intermittent hemodialysis, that CRRT ensures slow exchange or slow change in the electrolytes and the fluid balance, so ensure the absence of hemodynamic stress on the patients. Regarding intermittent hemodialysis, I will mention one important point, that small dialyzers are preferable to decrease exchange and the fluid and the electrolyte shift. Another point that I need to mention, that in intermittent hemodialysis, if you use in your patient, if he is hemodynamically stable, you may need to remain on daily regimen for longer time. So intermittent hemodialysis frequency in our acute kidney injury patient may differ from end-stage renal disease patients. Another point I want to mention in intermittent hemodialysis is the use of anticoagulation. It's better to use in newly dialyzed patients. It's better to use minimal or no heparin, because acute kidney injury patients are at high risk of bleeding. So it's better to avoid heparin as possible in first dialysis sessions. Regarding dialysate, as it is recommended by KDIGO and Oxford handbook, it's better to use bicarbonate dialysate and avoid lactate dialysate containing solutions. Another important point is the dialysate sodium. What if the patient you are dialyzing have low serum sodium? We will mention hyponatremia later in the electrolyte and acid-base chapter of acute kidney injury, and we will discuss how to dialyze a patient with hyponatremia in details, but to mention it in short here. If the patient has hyponatremia and you are afraid of rapid overcorrection of sodium in these patients, you have to use a dialysate with a sodium level less than or equal 20 millimole higher than the patient's serum sodium. And it was mentioned also here, maybe less than or equal 10 millimole above the plasma sodium. This will ensure to a high extent that the sodium correction will not be rapid. Regarding potassium level, if you have the availability to change the potassium dialysate, the dialysate potassium, you may change the dialysate potassium according to the serum level of the patient potassium to avoid rapid exchange or rapid change in the potassium level and to avoid arrhythmias. CRRT and SLED, we mentioned the most important points of them, and we will discuss, as I said, in more detail and depth these methods and techniques in our discussion of dialysis chapter in Oxford handbook. Let's summarize what we said in this case. This is case 60-year-old man admitted to the neurosurgical ICU after falling and sustained a traumatic subdural hematoma. So the patient fallen on his head and he has a traumatic subdural hematoma. He is evaluated with two contrasted CT over the first 24 hours of admission. On day 3 of hospital admission, the urine output decreases 0.5 ml per kilogram per hour. He is undergoing continuous monitoring of his intracranial pressure. Laboratory studies show sodium is good, potassium is high, chloride is good, slight acidosis, creatinine is 2.8, raised from 1.4, and blood urea nitrogen 53. Urine analysis showing muddy brown cast, diagnosing ATN. You recommended initiation of renal replacement therapy. What is the best modality of renal replacement therapy as from the evidence we discussed now, especially clinical guidelines? What is the best technique of dialysis you will use in this patient? I will give you 10 seconds. This is a patient with head trauma with subarachnoid hematoma and acute kidney injury with baseline creatinine 1.4 raised to 2.8. Yes, the answer is CRRT. The patient has increased intracranial pressure. As we mentioned that, we have to use CRRT if the patient is hemodynamically unstable or if the patient has increased intracranial pressure. What if you don't have CRRT? What will be your second opinion or choice? So if you don't have continuous renal replacement therapy, what will be your second option? Yes, I will use prolonged intermittent renal replacement therapy, 8 hours, which is slept. Okay. Another case, 60-year-old man with diabetes mellitus, hypertension, chronic obstructive pulmonary COPD, pneumonia. Over the next 48 hours, he developed ARDS, hypotension, and required hemodynamic support with vasopressors. He is now olivoric with stage 3 AKI. It is determined that continuous renal replacement therapy is the best dialysis option. So you decided to dialyze this patient. Which one of the following statements most accurately reflects current evidence regarding the most appropriate modality for dialysis of this patient? This patient needs vasopressor, so this patient is hemodynamically unstable. Which one of the following is the best to use? Yes, the answer is there is no significant difference in outcomes between diffusive or convective modalities. Diffusive modalities, these are the hemodialysis and the online hemodiffusion and the hemodiafiltration. The convective are the hemofiltration and the hemodiafiltration also. As we mentioned and said, that there is no evidence that one method of CRRT is better than the others. So I will summarize again. If the patient is hemodynamically stable, intermittent renal replacement therapy and CRRT have the same results, but we better to use intermittent hemodialysis as it is more available. If the patient is hemodynamically unstable, you have to use CRRT. Which method of CRRT is better? No method is better than the other. If CRRT is not available, you can use SLED technique to save your patient's life. What is dialysis equilibrium? That we are afraid of it. Dialysis equilibrium, there is a complication that may complicate first dialysis sessions in patients who are acutely dialyzed. The main idea that if this is the brain and this is the blood, the patient is uremic and have high urea level in the blood and also high urea level in the cells intracellular, and the brain cells have high level of urea. If we dialyze the patient early, the first one or two dialysis sessions. If we dialyze the patient for a long time, we will cause clearance of urea in high or in large volume from the blood. So the blood level of urea will decrease. There is an important point that the transportation of urea from the brain to the blood or from the cells in general to the blood is slow. So with high clearance of urea from the blood, the clearance of urea from intracellular compartment to the blood is slow. So this will make low level of urea of the blood in the blood after dialysis, but the level of urea in the brain is still high. And this will cause osmosis of water from the blood to the brain and cause brain swelling and increase the intracranial pressure and the presentation with central manifestations representing the disease which is called this dialysis disequilibrium. So dialysis disequilibrium is cerebral edema, because if the blood urea drops rapidly during dialysis but slow from intracellular compartment, this will result in water influx in the brain and cerebral edema. The patient generally present with convulsions, disturbed level of consciousness. But not all patients with central manifestation after dialysis are dialysis disequilibrium. You have to exclude hypoglycemia, hyponatremia, and if the patient is already diagnosed as drug toxicity. And you have to diagnose also intracranial bleeding, especially if you use the heparin. How to have a prophylaxis against this? Some units use phenytoin, loading dose, and maintenance dose. Some use hyperosmolar solutions as mannitol. Some give dexamethasone, but actually the best method to make prophylaxis against this is short dialysis session in the first hemodialysis session of the patient. How to treat? You have to stop dialysis and treat according to the presentation of the patient. If seizures, you have to treat, and also according to general supportive measures. So it's better to dialyze first dialysis session about 2 hours. But what if your patient is overloaded? If the patient is overloaded and you need to make a prolonged dialysis session, sorry, I have to mention first that with CRRT, continuous renal replacement therapy, the incidence of dialysis disequilibrium is usually absent, because CRRT is a slow technique. Disequilibrium is usually present with intermittent hemodialysis. So what if the patient is volume overloaded and hemodynamically stable, and I will use intermittent hemodialysis, and I need to dialyze the patient more than 2 hours to ultrafiltrate the patient and remove the volume overload? But I'm afraid of dialysis disequilibrium, because if I dialyze the patient more than 2 hours, he may develop dialysis disequilibrium. So you may use this technique. The first 2 hours of your dialysis, use the full dialysate flow and ultrafiltration. And after 2 hours, you have to stop the dialysate on your machine. Stop the dialysate flow on your machine. So now the machine is working only by convection and ultrafiltration, and you can continue your dialysis session doing only ultrafiltration. So if the patient is overloaded and you use intermittent hemodialysis and you are afraid of dialysis disequilibrium, use your full prescription for 2 hours, and after 2 hours, stop the dialysate flow. So you are now totally depending on convection and ultrafiltration. Finally, what is the dose? After we answered 3 important questions: when to initiate, when to stop, and what is the modality. What is the dose? How can I assess the adequacy of my dialysis? KT over V can be used, although AKI patients are metabolically unstable. So again, it has limitations, because KT over V depends on urea, and the patient is metabolically unstable, and there is variations in urea generation. But it is the only available measure to test the delivered renal replacement therapy. And what was recommended by KDIGO, that you have delivered KT over V of 3.9 per week if you used intermittent or extended renal replacement therapy. The delivered KT over V for acute kidney injury patient must be 3.9. Regarding CRRT, you must have delivered effluent volume of 20 to 25 ml per kilogram per hour. What is effluent volume? Effluent volume is the fluid that will go out from the machine, whatever the technique you will use. Those are the different techniques we use: hemodialysis, hemofiltration, hemodiafiltration, with different measures, as we said. All of these, you will have an effluent going out from the machine. The effluent may be the fluid that was ultra-filtered, the dialysate, all those. Here you have an effluent, here you have an effluent, here you have an effluent, here you have an effluent. Effluent is the volume or the ultrafiltration for hemofiltration, or the sum of ultrafiltration and dialysate rate for hemodiafiltration. So there is a target for this effluent. The effluent must be 20 to 25 ml per kilogram per hour. And to deliver this actual effluent, you have to prescribe a higher level of effluent on the machine. You will prescribe on the machine an effluent volume of 25 to 30 ml per kilogram per hour to get a 20 to 25 ml per kilogram per hour. Is there a benefit to get to dialyze a patient with high effluent volume, especially septic patients? Trials tried an effluent volume of 70 ml per kilogram per hour. We say high effluent volume if, or high dose CRRT, if the effluent is more than 50 ml per kilogram per hour. They tried to use high effluent volume. Actually, there was no any benefit of high effluent volume in patient with sepsis regarding any parameter. So the recommended delivered effluent is 20 to 30 to 25 ml per kilogram per hour. Let's answer this case. 55-year-old man with diabetes mellitus is evaluated for AKI, second to burn, and sepsis. Creatinine raised to from 46, the urea and creatinine from 46 1.5 to 105.7. Urine is low, less than 200 milli over the past 24 hours. Blood pressure is 160. The patient on vasopressors. CVB is 14 centimeter water. The intensivist caring for the patient asks you about high dose renal continuous. He wants to use a renal replacement continuous therapy with an effluent more than 65 ml per kilogram per hour. What is your opinion regarding high dose renal replacement therapy? I will give you 10 seconds. Yes, the answer is continuous renal replacement therapy, if chosen, should be provided with effluent flow rate of at least 20 ml per kilogram per hour, as we said, from 20 to 25. No, not at least 35. We don't need this. There is no method of renal replacement therapy is better than the other, and the randomized trials using a flow of effluent volume more than 70 didn't show any clinical benefit. There are other methods of dialysis using adsorption technique, a filter where cytokine may adsorb on the filter itself. I think this is experimental now. And also cytokine removal can be achieved whatever the technique you use. If you use high flux membranes, large bore membranes. Regarding vascular access of the patient, it is recommended that to start the dialysis but by uncuffed non-tunnel dialysis catheter. It's better to start by right jugular vein, followed by femoral vein, followed by left jugular vein, and finally the subclavian vein. It's better to use ultrasound guidance for dialysis insertion. It's better, and it is recommended to obtain a chest radiograph after placement of your of the catheter. And don't use topical antibiotics to avoid over the skin insertion, to avoid skin infection. and it is not suggested to use antibiotic locks for prevention of catheter-related infection in cats. Why we are afraid of catheterization? Because of the well-known complications of vascular access insertions as arterial puncture, hematoma, hemothorax, and pneumothorax. Regarding anticoagulation in renal replacement therapy, it will be mentioned, and we will discuss it later in the chapter of the dialysis of Oxford and the book Handbook of Nephrology and Hypertension. And there is a PowerPoint presentation about different techniques of hemodialysis anticoagulation available on nephrotube.com. But we will postpone its discussion later after we discuss the dialysis techniques and the last chapter of Oxford Handbook. Regarding peritoneal dialysis in acute kidney injury, it is not widely used, but it may be used in some areas or centers who serve AKI in children. And regarding the comparison of BD with different renal replacement therapies for acute kidney injury, studies are limited, but comparisons mainly have suggested a worse outcome for peritoneal dialysis than others. So it is not logical in a patient who is hemodynamically stable, especially if he has hyperkalemia and metabolic acidosis. To summarize, hemodynamically stable patients, you can use intermittent renal replacement therapy or CRRT. Hemodynamically unstable patient and patient with increased intracranial pressure, CRRT is preferred, and if it is not available, you can use SLED. If there is emergency indication, start renal replacement therapy immediately. If no emergency indication, consider broader clinical context, lab trends, and you have to take the patient as a general package. Let starting of renal replacement therapy in AKI suggested in the absence of urgent indications. Stop renal replacement therapy when creatinine clearance is more than 15 to 20, but usually in practice this is not used. Urine output is an important parameter when termination of renal replacement therapy is considered, especially if the average urine output is 1.5 liter. CRRT dose delivered effluent volume must be 20 to 25, and the prescribed effluent volume must be 25 to 30 ml. No evidence, and again we have to mention that KT over V must be more than 3.9. No evidence that septic shock patients will benefit from higher effluent volumes. Plasma adsorption may be used in septic AKI patients. Finally, thank you for watching and see you in another later lecture.